of the South Yorkshire, Derbyshire and Nottinghamshire Joint Health Overview and Scrutiny Committee on the 10th of October 2024. The meeting today is open to the public, so a warm welcome to members of the public who are in attendance. Thank you for coming. My name is Councillor Ruth Milsom. I'm the chair of this Joint Health Overview and Scrutiny Committee and also chair of the Sheffield Health Scrutiny Subcommittee. I'm just going to hand over to our Democratic Services Officer, Joanne, to read the housekeeping arrangements for us.
Thank you, Chair. Before we start, there are just a few housekeeping arrangements to mention. Please can I request that mobile telephones and other such equipment are switched to silent mode so as not to disturb the conduct of the meeting. There is no fire test planned for today. If there is an emergency evacuation, please take instruction from the council staff present. The assembly point is Tudor Square. The meeting today is open to the public and will be streamed live and for subsequent broadcast via the council's website. You should be aware that the council is a data controller under the Data Protection Act. Data collected during this webcast will be retained in accordance with the council's published policy. By entering the meeting room, you are consenting to be filmed and the possible use of those images and sound recordings for webcasting. Thank you.
Thanks very much, Joanne. So I'll ask members and officers in attendance to introduce themselves. So as I say, I'm Ruth Milsom, chair of this committee, and I'm going to go around to my left. So starting with Deb, and we'll go along if you can just introduce yourselves one by one. Thank you.
Thank you, Chair. My name's Deborah Glen and I'm the Policy Officer for Sheffield supporting this committee.
Hello, my name is Eve Keenan, Councillor Eve Keenan from Rotherham Council.
Good afternoon, my name is Kerry Grinsell-Clinton and I'm the Governance Advisor from Rotherham Council supporting Councillor Keenan today.
Caroline Martin, Senior Governance Officer from City of Doncaster Council supporting Councillor Glennis-Smith.
Councillor Glennis-Smith, I'm the Chair of Health Scrutiny on the City of Doncaster Council.
Councillor Mixto from Barnsley, I'm Chair of Overview and Scrutiny in Barnsley.
I'm Anna Marshall, I'm the Scrutiny Officer supporting Councillor Stone.
I'm Catherine Harkler-Road, I'm the Democratic Services Officer supporting Nottinghamshire County Council's Health Scrutiny Committee.
County Councillor Nigel Turner, representing Nottinghamshire County Council. I'm Vice Chair of the Health Scrutiny.
That's great, thank you very much indeed. Welcome everybody, especially new members to this committee. Do we have any apologies for absence today?
Apologies from Derbyshire Council.
And any items for exclusion of the public or press? None today. I'm to ask whether any members wish to declare an interest in any of the items of business on the agenda today. None, thank you. And so we'll move on to item 5, which is minutes of the previous meeting. These have been circulated in advance and members have had a chance to read through them. So I'm going to take this quickly to save time. Do members approve as a correct record the minutes of the last meeting held on the 25th of March 2024?
Approved, Chair.
Thank you. Councillor Smith speaking there because she's the only member of the committee, along with myself, who was there on that occasion. So we approve those minutes. Are there any public questions or petitions today?
We weren't expecting any, Chair, but we have had a lady come to ask questions about the terms of reference item, so I don't know if you want to wait until after to do that, after the item.
Thanks, Joanne. Yep, so public questions are normally taken in advance of the meeting, but since it relates directly to one of the items on the agenda, we'll take your questions today alongside that item. If that's all right, we'll bring you in at the relevant time. Okay, so item 7 is the terms of reference update for this committee, and Deborah Glen, our Policy and Improvement Officer, is going to explain the content of that.
Thank you, Chair. This was agreed at the last meeting. Well, there was an update at the last meeting about the changes that needed to take place to the terms of reference. And so the report has basically been prepared with that in mind. There is an addition that I need to make to the actual paper that's in front of you today. And it relates to point C in the actual document. And there's a suggested rewording to that section. Would you like me to read through the rewording? So section C should now read, to comment on and make recommendations about proposals in respect of which a relevant NHS body or a relevant health service provider is required to consult pursuant to Regulation 23 of the Local Authority, Public Health, Health and Wellbeing Boards and Health Scrutiny Regulations 2013, as amended by the Local Authority, Public Health, Health and Wellbeing Boards and Health Scrutiny Amendment and Saving Provision Regulations 2024, and exceptionally to make a call-in request to the Secretary of State. So essentially the committee is being asked to approve those changes to the terms of reference today.
Thank you, Deborah. Are there any questions about that part of the report? So just to be absolutely clear, the terms of reference for the committee are changing only on the basis of legislation that was brought in relating to the power of scrutiny to refer an item to the Secretary of State, which is now removed. We no longer have that authority. I've understood that correctly? Okay. Is everybody happy with the suggested amended wording, which just clarifies where that change has come from? Okay. And as I say, we do have a question, I think, relating to this item from members of the public. So, Nora, if you'd like, are you both going to come and speak? If you'd like to come up to the end desk there should be a microphone that will work for you. And just introduce yourself and give your question. Thank you.
Thank you. My name's Nora Everett. I live in Barnsley, and I apologise for the late notification because there's nothing on the website about your committee that says how questions should be submitted. So until I actually read the documents, I didn't know, and I apologise. My question is about the makeup of the committee. I've written it down as best I could on the train, so I'll talk very briefly to it. In Barnsley, there is an acute trust and a community trust with mental health, which covers mental health, learning disability, autism and dementia. And the community trust is South and West Yorkshire Partnership Foundation Trust, which covers Kirklees, Calderdale and Wakefield, and also reports to the West Yorkshire ICB. Any needs on those four conditions, it covers community needs as well, district nurses, health visitors, etc. Any needs of the Barnsley people are covered by that trust. And while you have overlaps with trust boundaries and ICB boundaries, I understand that in the former ICS, as it was, with Bassett Law included, and that some hospitals in Doncaster and Sheffield cover outside areas such as Derbyshire and Nottinghamshire, it was relevant in the old days, before July 2022, to have a wider committee. But surely now the committee should be coterminous with South Yorkshire council areas. And if you choose not to do that, then surely the three councils in the West Yorkshire ICB area should be included as well, given that the trust we rely on in Barnsley for community mental health, learning disability, autism and dementia health services or health needs, then they should be included in your committee as well. That's the first question. I don't expect an answer now.
Is the second one related?
The second one is also related to the terms of reference, in that it includes your role in ensuring that the needs of the population in South Yorkshire ICB covers are met. And I now don't speak as an individual, I speak on behalf of the Barnsley Mental Health Forum. We work at strategic level and have done for a while now, at least 4 years, working with 2 trusts and the Mental Health Partnership, which includes social care and public health, and is co-chaired by the South Yorkshire Place Mental Health Commissioners and the Public Health Lead in Barnsley. And we work continuously. We have input to strategic meetings of the Hospital Trust and of the Mental Health Partnership Delivery Group. And we were involved in developing the mental health strategy for Barnsley, and we recently did a service user review of that mental health strategy and reported to the Health and Wellbeing Board members, not the committee, the members after the committee. And in 2 weeks' time, we're doing a co-presentation with the mental health commissioner, he's manager or transformation and delivery manager for mental health in Barnsley, on the model of co-production that we're using at NHS England's Shine a Light on Co-Production webinars. In 2 weeks' time we're doing that as a model of good practice. However, although we work very closely and continuously to give service user voice and influence on mental health services in Barnsley, we are not connected with the Barnsley Place ICB or the South Yorkshire ICB on a regular basis, and we cannot influence, our service users cannot influence decisions that are made at South Yorkshire level for services that affect them. So I'm informing you, because it comes under your remit, under your terms of reference, that there is a disconnect with the good practice we're able to do in Barnsley for service users influencing their own services that they rely on, and at South Yorkshire ICB level, which is your remit. And I'll leave it there. Does that make sense? Does anybody need clarification?
Thank you, Nora. I think because we haven't seen the questions in advance, it's difficult to take all that in one go.
Of course.
So thank you so much for coming in. Can you just turn your mic off before you?
Thank you. I'm going to give this to you.
Thanks. Yeah. So thank you for travelling in, especially to deliver those questions. And they're things that we'll take away at South Yorkshire level, as you say, and also if Councillor Stowe might take that away from a Barnsley point of view, and just look at how you can interface with the group that Nora was outlining there, and just check that all the right communications are happening on that level. But from a South Yorkshire level, it's, as I understand it, Nora, what you're asking about is where decisions are made at the ICB level that would affect any of the places in South Yorkshire. And so there will be equivalent, there may well be equivalent bodies to the one that Nora was describing in the other places as well. So we'll take that away as an action to look at how mental health groups, advisory groups, are brought into scrutiny at South Yorkshire level. Is that fair?
Chair, can you just make sure
Councillor Stowe, yeah.
Can you just make sure that we get copies of the questions, please, so that we can respond? Thank you.
Yeah, so you've written the question down, Nora, haven't you? Yeah, so we have it in written form, so we'll circulate that straight after the meeting so it can be considered in all the right places. In terms of the first question about the governance here, Deborah will make some comment about that now, if that's all.
Thank you, Chair. Thank you very much for the question. I'm going to respond on behalf of the support officers that are all here in the meeting this morning. This afternoon. And if any of you want to chip in and add anything to this, then please feel free. It was discussed when we reconvened the this committee, the Joint Health and Overview Scrutiny Committee. We discussed whether it needed to be reduced to just include South Yorkshire. But there are a number of services, and one of them which is on the agenda today, which is oncology, which aren't strictly limited to those boundaries. So we decided that it was appropriate to continue with the membership that was already convened for this committee. If there were any other services, I know you mentioned the West Yorkshire areas. If there are any services that would need to be considered that covered a wider boundary, then we have the capability to call a specific JHOSC around that particular service issue. So then other local authorities would be invited to join that committee, but there's only allowed to be one JHOSC to be consulted with around a specific service issue. So basically, when we considered that legal requirement, we decided that what we needed to do was continue with this membership as it stands, and if there are only South Yorkshire related items on the agenda, then our colleagues from Nottinghamshire and North East Derbyshire are able to opt out of those discussions if they want to.
Yeah, if it's quick, Nora, thanks, but do come to the microphone because we're webcast, so people won't hear unless you're on a microphone. Thanks.
An example of the reason I asked the question: if you're in a mental health crisis in Barnsley, you come under SWIFT. And if you end up at A&E, you can be picked up by the police under section 136. Some of you will understand this, and I'll try and make it simple. And you're taken to the 136 suite at the local hospital. However, there's only one bed in each hospital area, depending on the population, obviously. One bed in Barnsley, and it's quite often occupied by somebody from as far away as Halifax, who also come under SWIFT, which means that a Barnsley person has to go as far afield as Fieldhead in Wakefield or Halifax, in the Canterdale and Kirklees area, which when you're in a mental health crisis is not good, when South Yorkshire is quite a sort of, I can't think of the word, it's a small place compared with the West Yorkshire area. There are reasons, and that happens. I mean, there are a number of 136s every week in that SWIFT deal with, so it's quite likely that anybody in crisis. I know there are discussions in South Yorkshire, but we're not involved with those, and I'm not sure what the Barnsley managers are about bringing that sort of situation into South Yorkshire.
What you're talking about is
it's just one example.
What you're talking about is things that might be dealt with at local level, or they might be dealt with at South Yorkshire it's ICB level. So what we need to do, I think, here is just remind people, I guess, that it's possible to raise things with a scrutiny committee that you would like the committee to look at specifically, and then if it needs a different JHOSC to be convened to look at that, we would do that, but we can't put multiple JHOSCs in place just in case. So it would need to be convened around a specific issue if that is something that is to be raised by the scrutiny committee. Do you see what I mean? So we can't just have, if you look at all health services, we would have a ridiculous number of JHOSCs to cover all sorts of different you know, co-located services. So I think it's a matter of, if there is an issue that you want a scrutiny committee to look at, is to take it to the right place initially, and if other members need to be brought in from another area, they would be at that point. So there is a mechanism to deal with the crossover of footprints, but it's not visible all the time because, as Deborah pointed out, we can only have one JHOSC convened on a permanent basis. I hope that makes sense. So, well, it's possible to convene the right committee for a specific issue, is what I'm saying. So that's just to be borne in mind if there are issues that you or your organisation want to raise. I'm sure there are similar issues in all sorts of places. I think the issue is, if there's a specific health service concern, is to raise it at the most appropriate place initially, and if a bespoke scrutiny committee needs to be convened to deal with that, it would be. Okay, thank you. It's not ideal, but then, you know, we've got footprints set out nationwide that don't fit all the services that are delivered, so we have to try and work within that. Right, we are going to move on to our next item, which is a substantive item on non-emergency transport service eligibility criteria, and we have some ICB colleagues with us to explain the report. And have you got a presentation for us?
We're going to talk through the paper.
Is it verbal? Okay.
Excuse me, yes.
If you'd like to all introduce yourselves and just describe your roles, because they're not on your name cards, if that's all right, and then go ahead with your presentation.
So I'll start, Ruth. I'm Dr. David Crichton. I'm the Chief Medical Officer for NHS South Yorkshire. As well as fulfilling that role, I'm the Executive Lead for Urgent Emergency Care, and that's where this programme of work is housed.
Good afternoon, everyone. I am Leslie Carver. I work for South Yorkshire Integrated Care Board, and I am a Programme Manager within the Urgent and Emergency Care Alliance.
Good afternoon. I'm Chris Dexter, Managing Director for Patient Transport Services for the Yorkshire Ambulance Service.
I'm Richard Kennedy. I'm an Involvement Manager at NHS South Yorkshire.
So we're going to take a bit of a team effort. I wasn't sure how long we had, but we will be concise, and that will give us time to have a conversation. So I'm going to open up. You'll see in the paper that we're bringing to you today a review of and actually introduction of a new eligibility criteria for non-emergency PTS services. This comes on the back of a number of reviews that have been undertaken nationally and a publication from NHS England to align eligibility criteria actually across all of England. There was engagement before that publication by NHS England through Health Watch and alongside charitable groups and patient groups, and the conclusion was that actually the previous eligibility was needed radical change. We're responsible as the commissioners for the service within the National Health Service to oversee specific local guidance to determine the eligibility and authorisation and assess the needs of the population. One of the stipulations within the publication was that this was implemented as soon as possible, and we hope to undertake that. In the opening section, there are a couple of elements probably to pull out, is that while we're looking from a South Yorkshire perspective today, because we have a provider in Yorkshire Ambulance Service that cuts across South Yorkshire, West Yorkshire and Humber and North Yorkshire ICBs, we do come together to converse and to come to conclusion and agreement on this. And I guess it really picks up from the public question you've received today, is that actually we don't live in an island and we do interact with wider partners. So we have an executive leadership board, which I represent South Yorkshire on, where we come together to make it fair across the system. I suppose the other bit, although it's not the predominant reason for implementing this, is the financial pressure that we currently have within the National Health Service, and I'm sure across local government colleagues. So I think it's important that when we have the conversation that we prioritise those services for those who need it most. I'm going to hand over to Leslie to just pick up some further bits within the paper, and then we'll bring Richard in.
Thank you. As David mentioned in the paper at the beginning, it talks about the reviews. So back in 2007, there was a review that talked about the eligibility criteria, which is in your paper that you can see. Subsequently, in 2022, a national paper detailing how we should go about that for the eligibility criteria has come out, and it actually recommended that most people should travel to and from hospital independently by private or public transport with the help of relatives or friends if necessary, and that there should be a standard national approach that defines the eligibility criteria for non-emergency PTS and replaces all local arrangements. So that's what we have been working on with this particular paper. So we've identified two risks with the change from the local to the national eligibility criteria for the NEPS service. So NEPS refers to non-emergency patient transport. So risk one is that there are more individuals across South Yorkshire being eligible for NEPS because of the change from the local to the national eligibility criteria, resulting in more individuals missing or potentially facing delays in their secondary care treatment. The other risk that we've identified is the impact of the individual eligibility criteria is not equal for everybody. So across South Yorkshire, some individuals might not have the means of independent travel, resulting in more individuals from disadvantaged and unrepresented communities missing or facing delays in their treatment. So we've been working to understand and assess each of these risks, and the ICB's done this particular piece of work. So we've done a South Yorkshire local impact assessment, which is in your paper. The full impact assessment can be found in Appendix B. What we wanted to look at was identify how many individuals the changes to the standard eligibility criteria could impact upon, identifying, considering the variation in individual use as well, and also considering deprivation and rurality as well. We found it's anticipated that the new criteria will impact on those patients currently identified as requiring standard or saloon car or W1. W1 relates to wheelchair users requiring no additional assistance. In your paper, you will see a table which looks at the number of journeys by South Yorkshire population, and we've pulled out some key messages. So there was a total of 78,130 journeys for people using standard care or wheelchair users that are likely to be impacted by the new policy. Deprivation is a significant factor in the use of services, with 45% of patients accessing our NEPS that live in the most deprived areas across South Yorkshire, and only 6% live in the least deprived areas. Those accessing the NEPS from the most deprived areas are overrepresented compared to the general population, where only 37% of South Yorkshire live in the most deprived areas. This pattern is observed across all places across South Yorkshire. It is anticipated that the policy will impact on our older population, given the majority of people accessing the service are aged 66 and over. However, it's notable that the NEPS users in the deprived area was younger than in the least deprived areas, reflecting the higher levels of poorer communities using this service. Whilst the numbers are low for children and young people who use the service and live in the most deprived areas, are significantly overrepresented. Over 76% of journeys in the age band were from the most deprived areas, compared to only 43% of the general population, suggesting that children from the most deprived areas will be more impacted than other groups. Men were slightly more likely to be the users of the NEPS service, which isn't in contrast to the pattern of the general population in South Yorkshire, where it's generally more women that are affected. It was notable that the higher numbers of men was largely due to being men from using the service for the most deprived areas. The pattern of service used by ethnicity was represented of the general population, where 87% of the service users were white, which is the same as the proportion in the general population. Of note, NEP service users who were from non-white ethnic groups were more likely to be in the most deprived areas. 72% of journeys by mixed ethnicity groups were from those who lived in the most deprived areas, much higher than the average for South Yorkshire, where 45% of users lived in the most deprived areas. I'm going to pass over to my colleague now, Richard, who will talk about the involvement piece of work that we've done.
As David mentioned, the guidance that's been put forward by NHS England was subject to a national involvement process that resulted in the guidance that we've been presented with. But for us, it's always essential that we understand the local context that those things kind of come in. So for us, we undertook a local involvement around that to supplement the knowledge and try and understand what the impact would really be. So we did that over the summer, the 6 weeks, a 6-week period in which we received 56 individual responses, as well as some really good feedback from Healthwatch and the Sheffield Children's Hospital as well, which they drew upon insight from feedback that they'd received from patients just generally about patient transport services and their use. So although kind of 56 responses isn't necessarily quite as many as we would have liked, I think one thing that we do know from the feedback that we got is that the concerns that people had been heard kind of quite loud and clear through there, and are in keeping with the findings from our impact assessments and the data finding assessments that Leslie's spoken through there. I think for us, it's the point of involvement is about understanding the impact. It's not necessarily about getting any sort of consensus or something like that. It's about understanding what the concerns are, what the impacts could potentially be, and through that, I think, like I say, I think we have heard that loud and clear. So we do know that there is a concern that people feel that they patient transport is an essential part of their care, and for those that need it, if it wasn't available to them, it would limit or stop their attendance at hospital appointments. They're concerned about impacts on their families as well, if they are expected to help out more than they currently are. There was a concern about those that are most vulnerable in our society, those with disabilities and health conditions that require specialist support and escorts to aid them in their transit to hospital. There were some concerns about the criteria itself and just the understanding of it. I think people wanted to know exactly what that was. I think they wanted to see if they would be affected personally by it, and I think it was something that we struggled to get across exactly what that criteria was, so people could make their own assessments for that. And there were questions about specialist treatment. So as we move to as people move to more specialist treatments, there are often requirements for further travel outside of South Yorkshire, and people had questions about whether that would be covered. One of the things that we always look for in involvement is asking people about what would make things easier for them. What is it that what difference could we do that would make things easier for people? And people were very clear that they wanted more support for those who are most vulnerable with disabilities, mobility needs, and older people. That they wanted us to consider individuals' needs when it came to it, and there would be an individual assessment on everybody. that they wanted to see improvements to wider public transport, and they also wanted to understand what alternative transport arrangements could be available to them if they weren't eligible for patient transport. They wanted to look at improvements in parking arrangements at hospitals, which I suppose kind of points to the fact that people maybe are able to, but they may have their own transport, but they have issues with using that transport, and parking arrangements is an essential part of that. And also about just information. I think really wanting information about what the public transport timetables, what public transport was actually available, what alternative, and also what financial assistance was available. There seemed to be a very low knowledge of the and I can't remember the exact name for it now, the healthcare travel cost scheme. So that is definitely something that needs to be taken into consideration.
So with the involvement work and the impact work that we've done across South Yorkshire, we're now looking at what alternatives may be that we could look at to be able to mitigate some of the risks that we've highlighted. So as a contracting authority for the NEP service, there is an option to include additional eligibility criteria for those that are nationally set. So this could be that we may want to look at putting additional transport on in areas where we feel that there's a high frequency of treatment, that there's long distances to travel or high costs associated by travelling by taxi, and also limited complex public health transport. However, there is a cost attached to that. So we are working through that as a possible mitigation. As Richard mentioned, the use of community transport alternatives as well. In South Yorkshire, we have amazing voluntary and community sector organisations, but also reminding ourselves that there will be a cost attached to that as well. So that we are looking at doing a full assessment of the potential use of community transport alternatives in areas where we feel that patients will be affected most. And Richard also mentioned the healthcare travel cost scheme as well. So this is further information is provided in Appendix G, which provides a summary on how this actually works. But in practical terms, it's where an individual, if they don't meet the national eligibility criteria, they would, and they are means tested, they would be able to apply for the money that they've paid for their transport back. And there's two ways of doing that. That is either through the hospital, where there are cashier services where individuals can go up and claim their money back directly. However, we don't always have cashier services in all the hospitals, and if a individual was out of area, then that's even more difficult to be able to claim that money back. The other option is that it can be done by a form, and that form's got to be filled in and the form gets sent off, and that's got to be done within 3 months with receipts of using transport. There's no actual time limit on that money coming back to that individual. So we're looking at how we could make that a lot easier for individuals. So if individuals are having lots of journeys in 1 month, they may put lots of receipts in, but that means that they could be waiting quite a long time for that money to come back to that individual. So we're working across with our other ICB partners to see how we could speed up that process potentially. So those are some of the things that we are looking at against mitigation, about what we've explained in the paper so far.
So just to end before we open it up, the next steps was actually one further point to add. When you look at the actual eligibility criteria, it is quite broad. It includes medical needs, it includes cognitive and sensory impairment. It specifies renal dialysis patients being a separate category to be supported. Safeguarding considerations and wider mobility and medical needs are all included in the eligibility criteria. Our plans are that we would take this to our public board in November, but clearly we would welcome your views and feedback to help us take this work forward. Thank you.
thank you ever so much. I'm sure members have got plenty of questions around this. So I'm just looking at the time because we've got another substantial item after this. So I think we'll try and limit ourselves to half an hour, members, if that's all right. So we've got plenty of time for the other item. So any questions, Councillor?
Yeah, thank you very much. A couple of questions, and specifically around the complexity of being able to apply. Is there no way that we can simplify? Because it seems that everything we do is complex, and it's very difficult in terms of individuals. We mentioned 66 and over individuals, and I'm not ageist, but the point's got to be that the more complex it is, the more difficult it is when we get to my age. So is there no way that we can simplify that before we move to that?
I was just trying to get a bit more understanding there, because age in itself, you know, people's ability at the age of 66 is very, very variable, isn't it? If you have lots of medical conditions, you are going to be impacted upon more, whereas some 66-year-olds may be more mobile. I mean, the process of patients being provided with patient transport is done through a booking service that I think, Chris, you might be able to add some additional information on that. So there is a process where staff who identify patients who need the support, you know, contact the booking service to you know, get that confirmed. Would you like to come in?
Certainly. So in terms of the booking, patients can make the booking themselves through our call centre, and they'll go through a set of the eligibility criteria questions, and we would have supported measures in with that call centre, being part of the ambulance service, in terms of being able to support people should they be struggling with the complexity. The other way in which bookings are made are through the healthcare professionals who are either running that clinic for planned care or possibly for discharging a patient and so on. So that would be done through that healthcare professional or the administration that's within that place. So in terms of the complexity, I think Leslie was talking about, I think that was more around the healthcare travel cost scheme, which, yes, it is quite cumbersome in terms of the number of forms that are needed to be filled, and I think that's something that's being reviewed within South Yorkshire and with other partnering ICBs. If the financial reimbursement is the real need that person is looking for, then they're looking at a simpler way of doing that.
Yeah, and as a supplementary to that, you made reference to deprivation, and on indices of deprivation, Barnsley is well behind other areas. And we do know that for public transport, to get from Dearn to Weston Park takes 1.5 hours. Train, bus, walk. But we've got a position when we talk about deprivation, it's about income and expenditure, and in terms of affordability, if they have got a number of visits in a month, for that money to be laid out to wait for it to return, I think what could be an easier method is an opportunity for bus pass when necessary, so there's no outlay prior to arriving. And when we talk about hubs where they can claim the monies back when they get there, that needs to be universal. Because if someone's got a number of appointments, they potentially couldn't afford to go to those appointments, so they're going to miss, and that's going to leave a cost to missed appointments. So I understand it's complex, but I think we need more simpler solutions for that.
I think we'll acknowledge that. We'll take that away. I mean, I'm a GP by background, so I kind of, you know, come across this every day, and the simplicity of the eligibility, I think, is what picked up what you're highlighting.
Yep, Councillor.
So we talk about eligibility criteria. My background's in learning disabilities. I'm always very conscious that there are are a group of people, the ones who don't live with family, who aren't cared for by other people, who are just about managing and who need that information conveyed to them in a format that they can understand properly. So are we doing that so that it's very much easier? And the other thing I would say is that won't just serve the learning disability population, that'll help the elderly population, people with dementia, somebody who's had a stroke. It helps a whole raft of people, but that information's got to be really well done and able to be understood.
Do you want us to respond, Glen? So I think that's a good point for us to sort of ensure that that's included. I mean, as I laid out in the criteria, I mean, cognitive impairment is one of the criteria to get it. I think the understanding is if you're deemed not to meet the criteria, how is that explained back, or how's, you know?
Community transport. I'm looking as much as I was with the Scrutiny with South Yorkshire Mayor. Last meeting we looked at community transport and the fantastic job the community transport are doing. But is it not the case that this will put added pressure on that community transport who are stretched already? So what would we be doing? Because we always said there's a cost to it. Could we or could yourselves invest in that community transport to raise their opportunities to expand, to develop the service which is more focused in local communities, especially in communities of deprivation?
I think I'm happy to respond to that as well, Mick. One of the things I haven't mentioned so far is that the new structure of the NHS with integrated care boards is we work much closer with the mayoral combined authority, and actually we're inputting into the work that they're doing with regards to public transport. So, you know, other transport needs, do they match the health needs and people's ability to get to hospital appointments and that? So that's an ongoing piece of work. That won't be completed in the time frame we're talking about this. The reality is that, as I highlighted early on, the financial situation is difficult, and you know we would love to invest in other avenues to support people. Now, sometimes they happen, and when you hear the next presentation on non-surgical oncology, we have provided some transport services to support that, so that may be picked up, that kind of connects to this. We're always looking to work with voluntary sector and community groups to see how we can help them both with resource but with kind of other means to you know, put the needs of the person and be supported there. So it continues to be a challenge. I think we have developed our relationships a lot better with voluntary sector workers, and I think there's a lot offered by them, and I think we are very appreciative to them. I think sometimes the feedback we get is often that we rely on them too much. And actually, the balance is kind of, you know, while we couldn't work without them, that equally, you know, we you know, there's a risk that we overstretch them and actually they become overcome. So I think it's a constant challenge we're always considering in all of our involvement work that we undertake. So, you know, we look for other income resources to expand the services we've got, but I think all of us are, you know, it's difficult for us.
Thank you. A couple of questions, just briefly on the eligibility criteria. How will these judgments be made? Yeah, I find that an interesting one, and also getting quite parochial, because I've lived most of my life in Bassaloir. On the reporting that you've got within the documents, there's very little mention of Bassaloir. I understand that it comes under the Doncaster banner, but is there a report that we can have that includes includes that for Basildore.
So with regard to the length of the eligibility following the booking, if it's for a patient who has a course of treatment for planned care, then that would be reviewed after a 12-week period to see if there's any change in condition, and that's standard again as per the guidance and advice. If it is for different reasons, and an example I could give would be someone who may not be eligible going in for an appointment to do with an injury to their hand or something like that. However, they are then booking in for appointment to do with eye clinic or something like that, and they may not be able to drive or something. There could be varying reasons. So on each and every occasion, for different appointments, that individual would be asked the set of eligibility criteria questions.
If I could come on the back of that, although we're talking about a new eligibility criteria, there are eligibility criteria that exists already. This is a refinement of that, so we are implementing, and we do use eligibility criteria at this point in time. There is changes to it, and that's what's going to be different. So the processes of how you book patient transport currently won't change. It will be the same access points via the direct contact through the provider or through healthcare provision. I think the second point about Basset Law is we recognise, and we always have done within South Yorkshire, because we used to be an integrated care system that was South Yorkshire and Basset Law. There was realigning of boundaries that meant that Basset Law moved to Nottinghamshire. What we don't have responsibility for and what I don't have direct control over is East Midlands Ambulance Service. So some patients in Basset Law may go into the Nottinghamshire service, and I'm not able to provide that. But what I can do is the patients who are, because Doncaster Basset Law Teaching Hospitals is an entity, and we do oversee both parts of that trust, is that any report that we bring back further should include the patients who are flowing into the South Yorkshire system. So I'm not sure if that was what you were asking, if you want to clarify.
If you could really sort of dial down onto Basset Law figures. I'm getting a little parochial here, but really, I've lived my life in Basset Law, and we sit right on the cusp of.
You do.
And it'd be nice to see some actual figures just for Basset Law, if that's possible.
I mean, we can look into that. I mean, I don't want to come across and saying that's not my responsibility, because historically we've always worked with the trust and we recognise the patient flows in here. So I think once again we'd look to do that for you. Yeah.
Thank you.
So, and just in addition, the provider in Nottinghamshire, so possibly it might be the commissioners who have the majority of the source of information that you're looking at, including the information for patients from South Yorkshire travelling into Basset Law. But I believe it's an organisation called ERS or Exec. So I think it'll be a commissioning question. They should have all the minimum data sets and all that information that flows through each of the contracting leads.
Thank you.
Okay.
Thank you. I've got a few questions then. So I'm thinking, just referring back, David, to what you said about engaging with the South Yorkshire Mayor, which is seems really key in all of this, because there must be patients who are using the transport services because there is no bus service, and they would otherwise be independent and use a bus. So it's a really obvious area, isn't it, to delve into, and we're hoping for a franchising arrangement for South Yorkshire, which will give us immediately a lot more control over those routes and timetables. So there could even be specific hospital buses that come on stream, but that's obviously not for quite a while. As part of those conversations, are you also looking at potentially, you're talking about ways to mitigate the difficulties around claiming back travel costs under the healthcare travel cost scheme? Might there be a scope for passes to be a solution to that?
I think that's certainly something for us to look at. I mean, I've supported people in applications as a general practitioner, but that's not in my gift for them to be agreed. I think the bus pass system does sit with local authorities, of my understanding. So I think I don't think that's something we've necessarily looked at this point. Leslie?
No, it isn't, but I absolutely agree, Ruth and David, that that is a really good idea. And also what we're looking at the moment across the three ICBs is that the number of forms that somebody's got to fill in for the number of times that they've been to the hospital, can we not simplify that? Can we just not have one form? You know, or can we not have somebody there to be able to support that person to fill out the form as well? So that's what we're looking at collectively.
Yeah, that's good, thanks. Also just wondering about, so this large cohort of patients who currently rely on saloon car transport, and that you've identified that cohort as at risk under the change of eligibility criteria. So what are I mean, I've read through the report from NHS England on this, and it's not clear what alternatives really are being suggested for that cohort of patients. So if you're saying they're at risk of losing that eligibility for a saloon car transport, if there's no viable bus alternative or a relative who can drive them, what are the options for those people?
So we are looking, as I say, at the community transport to see if that's available in the local areas where we know those people are going to be impacted. And that's one of the recommendations that we would take to the board as well. So there is some scoping work, working with our volunteering community, as I say, to see what's available for those that will be at risk.
And those would be commissioned.
Well, I mean, in the report you'll have picked up in one of the opening paragraphs that the premise was that, you know, there'll be an expectation, if you're capable of, that most people would find independent means to go to appointments and that. So we can't hide behind that. That is there. So I don't think it's all about replacing current provision with something else. But there will be people who fall into the criteria who will continue to be provided with that. But I think that's the crux of the question here, is what happens with the people who currently are who are deemed to be eligible, who would not be going forward. And you know, we will look to put as many mitigations in as we can. But if we're thinking that the full current cohort are going to be provided with something alternative, I think that's probably not the case.
So off the back of that, how closely will individual cases be monitored for, you know, are people going to start missing appointments or not seeking healthcare at all because of this? How will that be monitored closely and addressed if it happens?
So one of the things about the eligibility criteria, and we've been talking with the current provider, Yaz, I say current because obviously these contracts come up for renewal and there are changes that happen, is some appeals process. So, you know, I think it's important that people who are declined have an opportunity to put their case. Now, we need to be sensitive of that, because that occurs at a point in time, but the appeal may not, it's not going to be immediate, is it? So that's something that is part of the eligibility process. Forgive me, what was the other point, the question, Ruth?
It was just about how, you know, if someone drops, effectively drops out of the healthcare they should be receiving, how are they going to be brought back so that they're not at risk?
I mean, patients not seeking care is a difficult one, because that's quite hard to measure. But DNA rates and not brought for treatment, if it's a young person, we do monitor that. So that is something we have data for. So once again, I think that is recognised within the paper about that was one of the risks that we'd identified. So that's something we need to closely monitor. I think in any implementation of any plan, I think there is that need to, it not just being a point in time, that we continue to review it and we make changes based on anything that comes to light going forward.
I mean, this might be too hard a question for today, but really, how possible is it to plan and commission sustainably in this respect, in respect of transport, when there are service transformations ongoing in the whole healthcare system? Like, how you can't plan now and commission now sustainably for we're looking at cancer services in a minute, and that's undergoing transformation, and you know, there may be new clinics, there may be clinics closing down, that, you know, the actual transport needs of people might change, well, inevitably will change, and that's just in cancer care. So how can you commission sustainably, given how many changes are likely to occur in where patients need to be?
So I'll start off on there. I mean, I've been a doctor for 30 years, and the services we provide now are different from what we've done previously. So I think I envisage that the health service will continue to change as much as it has in my lifetime as a doctor. We've got the Darcy Review, which has been published, which is slightly broader than our conversation today, but that in the spring we expect to have a 10-year health plan published, and I think within that will give us a bit of a steer of what are the priorities for the Department of Health, and then what the response is from the NHS about developing services. So I think that's a good question. It's an important one, and it's one that we continue to review. We're on a bit of an annual cycle of planning. It doesn't feel quite enough to establish a sort of medium-term strategy, and we're hoping that the 10-year plan will give us that. Chris could probably come in with the stats, but we have seen a year-on-year increase in patient transport services. So the number of patients who have accessed this and been supported to be attending. So that's something we've seen consistently on an annual basis without necessarily putting a correlation about changing services and usage. And I think that comes back maybe to some of the councillors' points today about the burden of disease. So multimorbidity, actually, you know, in South Yorkshire, we do see, you know, our index of multiple deprivation is twice the national average. So, you know, we do see more people who have health needs greater than we do in other parts of the country. So as commissioners, you know, it is our responsibility to support people for that. Do we ever feel we get twice the amount of money for that? No, but we, you know, try and do our best for the people that need that most. Chris, I don't know if you know roughly how much, you know, year on year we are seeing.
Yeah, so we delivered just under 200,000 journeys in total last year, and for the same period from April through to August, we saw a 12.5% increase just in demand. That was across all mobility types, so it wasn't new patients coming into it or finding a way through eligibility. It was through more complex, higher acuity patients as well. So you know, we're forecasting now to be above 200,000 patient journeys, quite possibly this year. I think, just into Leslie on the potential impact will involve around 70,000 of those patient journeys. In terms of those questions around the car patients and the wheelchair one patients, some of those of which will continue and they will remain eligible, but that will be the primary area that will be hit, yes.
Are we maximising the number of appointments that could be done virtually and or telephoned as part of that analysis, or is that going to be part of the 10-year plan?
I think it's part of how we provide healthcare, and people will be aware that during the pandemic that there was a lot more usage of video calls, telephone calls, and I think that's been embedded fairly standard in general practice now. So there is always opportunities to use virtual increase in technology. I think the Health Secretary committed to three things, and I think analogue to digital, using more digital solutions, is one of the things that has been mentioned. I think the second thing is care closer to home, so you don't have to go to more appointments. And I think the third thing that was mentioned was getting upstream with preventing people getting sick in the first place. So I think these are all important considerations alongside.
And as part of that, when we're talking about areas of deprivation, we could look at virtual hubs in deprived communities that could be run through community groups and organisations as part of that. For example, take Grimethorpe. The community groups and organised within Grimethorpe, which would love to be able to develop that service, because that could be used by a wider community there. So it's always a possibility, but what we've always got to look for is a stream who's going to fund that. So again, that's where voluntary sector can come in and fund a finder and find out where there's opportunities to do that. But that will then complement the health service and local authorities in what they deliver locally. So just a plan.
Sorry, I mean, just to reflect, I was at a digital inclusion event yesterday at New York Stadium in Rotherham, in which there was a wealth of different things that are now available and are being pushed forward. So digital inclusion is a massive part of the ICB's work. And again, working in partnerships. So the event yesterday was had representation from the voluntary and community sector. Citizens Advice Bureau do an absolutely amazing job at doing exactly that, and we can see that there will be more of a gradual shift and more kind of remote access where it works for health services and for the individuals receiving it. But there is a lot of work that goes as well to help people to access that through to address digital poverty or digital literacy, whatever the barriers they may be. So it is a piece of work that the ICB are working heavily in partnership across South Yorkshire on.
Are there any other questions? Okay. Sorry, just finding the right page in my report pack for the recommendations. So this committee is asked to note that there are new national eligibility criteria for NEPT services to replace the current locally agreed criteria. We've all noted that. And secondly, to review and provide feedback on the work that the South Yorkshire ICB is undertaking to understand the implications of implementing these criteria. Do we feel that we've understood everything that we need to today? And including the assessment of risks and the development of appropriate mitigations. Are there any outstanding questions, or would members like any further information on anything that hasn't been answered today? Are we
Yeah, an update report in 6 months, 6 months.
Mm-hmm.
Yeah.
Councillor Smith?
I would like some further information on the information that's put out there for people with learning disabilities and neurodiversity. Thank you.
Anything else? Okay. So just referring back to the timescale of the work that you're doing, would a 6-monthly report back to this committee seem appropriate?
We'll make it work, Ruth.
Is that okay? I think it's a sort of sooner rather than later. If we leave it a lot longer than that, you know, more questions may have arisen in the meantime for us. So 6 months might seem quite soon, but I think that's probably appropriate given the speed that the work is taking place. Is that okay with you?
Yeah, I mean, there's work going on in West Yorkshire and Humber and North Yorkshire as well, so we might be in a place where we might be able to, there might be some themes that cut across the 3 places that are relevant to us all, so we might be able to bring a broader report. Can I just thank yourself and the committee, because I think what you've highlighted is some broader elements than non-patient PTS, and I think we'll certainly give them some thought, and thank you.
And in terms of the public transport and the matter of buses and the mayoral authority, I think, you know, rest assured that members here and other members, elected members in all our authorities, you know, are also chiming in with the consultation that will be forthcoming about that. And we're all keen to see the right services in our communities. So hopefully our work complements each other in that respect. And we know that Oliver Coppard, the mayor, is very receptive, so we're grateful for that as well. Thank you very much for your time today and answering all our questions so fully. Really appreciate it. Thank you. quick change of personnel, just take a moment. Okay, so our next item is a report on non-surgical oncology, and this is not the first time we've had a report from you on this subject. I think it was December last year that we last had a report at Public Committee, so looking forward to hearing the latest updates. And then members will have questions. If you'd like to introduce yourselves and describe your role, and then go ahead with your presentation.
Sorry, new technology. Hi, I'm Trish Fisher. I'm an oncologist at Weston Park. I look after people with lung cancer in Sheffield, and I'm also one of the clinical directors of the Cancer Alliance.
Hello, my name's Mark Tuckett. I'm Chief Strategy Officer at Sheffield Teaching Hospitals, and my portfolio includes cancer. Thank you.
So we do have a presentation, and I apologise to those of you who've heard me talk on this before, as I will be repeating myself because it has been a little while since we last came to see you. So if we could just make sure we've got the right presentation by moving it on a couple of slides, because I think we submitted 2 presentations. Yeah, oh, okay. Oh, that's me, is it? Lovely. Do you want to? Shall I just say next slide?
Is that the one you were expecting?
Yes, yeah. Lovely.
Just go back,
yeah. So we're here today mainly to update you with some of the things that we have talked to you about in the past, particularly around the programme, and on this occasion the lung cancer clinics. We've talked extensively about breast and some of our other services, but the more recent changes are around lung cancer. But next slide, please, just to go through some of the background again to refresh everyone's memory. We have a national shortage of consultant oncologists, and you can see on the pictures on the right-hand side that currently we have about a 70% shortfall, and that's predicted to become about a 25% shortfall in the next few years. And quite a lot of jobs that are advertised currently go unfilled, up to about half of them. There is a definite north-south divide, unfortunately. A lot of trainees are based in the south of the country, and by the time they are qualified, they have wives with careers, husbands with careers, children in school, and they don't like moving. The other thing about Sheffield, whilst it's an absolutely glorious place to work, we are quite small and in the wrong part of the country in terms of our proximity to bigger cancer units such as the Christie, Clatterbridge and Leeds, who have certainly in the case of Manchester, have some very exciting technology that tends to attract people to go and work with them. At the same time as our workforce is shrinking, our demand is increasing really quite significantly. We're seeing a lot of increasing cancers in younger people, partly related to lifestyle, but clearly also our demographics are such that our population is ageing, and cancer does tend to be a disease of older people. However, on top of that, we have seen a huge surge in the treatments that we're able to offer, which is fantastic, but we have NICE approving between 45 and 50 new treatments a year without any help with the infrastructure, although that's supposed to be changing. And therefore, we're seeing people who have multiple lines of treatment going on over many years, combinations of complex treatments that are quite challenging to monitor, and we are essentially victims of our own success. We have, for a lot of people, changed incurable cancers into a long-term disease.
We also know that because of the way that the services have grown up across the patch, that we have had historically variable amounts of oncology inputs into our local DGHs and therefore variable access to treatment. We've done a lot of work knowing that we don't have enough consultant staff to be able to manage the workload in terms of developing the whole of the multidisciplinary team. So for instance, I've just come from a clinic where I'm working with a physician's associate, and I know there's been a lot of bad press, but appropriately used, they're fabulous. I have a GP working alongside me. I work with a parallel clinic of HCP nurses very highly trained to supervise a lot of our routine treatments, and I work with two fabulous radiotherapy lung therapy radiographers who do a lot of my radiotherapy for me. And essentially, I'm sure a number of you have heard me talk before about the fact I was trained to play a violin, but now I actually conduct an orchestra. And a lot of those people do a lot of that work for us, and we oversee those pathways. And in addition, we have had significant technology advances, not just in terms of all the whiz-bang kit I have in radiotherapy, but in terms of the ability to have meaningful virtual interactions that involve more than a telephone. So there's a lot going on and a lot that we're looking at. So we have for a long time been doing next slide please. Oh, okay, somebody's operating it. So non-surgical oncology, NSO, is everything oncological that doesn't involve a surgeon. So that is radiotherapy, that's our systemic treatments, which is not just traditional chemo, but immunotherapy, targeted biological treatments, etc., etc. We started this programme by looking very specifically at the outpatient services that we delivered. But there are an awful lot of codependencies in terms of the workforce and all sorts of other stuff. So we have widened it out to look at inpatients, acute oncology, which is when we make people ill either from their cancer or their treatment and need to look after them, and radiotherapy as well. It's really quite difficult because you want to chunk it down and tackle a problem, but you have to look at the whole of the elephant while you're doing that. What we're trying to do predominantly is improve the safety of our service and reduce the risks, because a number of you will remember when we first came to you that we had some severe concerns about the safety of our breast cancer services, and we're talking about making some very major changes because of that. We're also conscious of the inequalities. Obviously the ICB and the Alliance are all about trying to make sure that we are offering the same to everybody. But we can't look at any of this without being able to have a resilient and sustainable workforce. So a lot of the focus has been on how can we make our workforce more resilient. What we're doing, obviously we had initially a couple of years ago to be very reactive to a crisis and make some changes very quickly. But as we're going through this, we're trying to do things in a phased way, to test different approaches, to make sure we get feedback from the people affected by those changes so that we can then feed that into the next phase of change and learn from it. We may not always get it right, but we're trying to improve it as we go along. So at the beginning we did a very extensive, yes, next slide please, we did a very extensive exercise trying to get feedback from the public and from people who had used our services, and we've been through that in some detail with you in the past. In terms of making sure that we knew what matters to people, obviously safety and outcomes matters to everybody, travel and access matters, but there was a big theme both from the patients but also from the staff that the continuity of care is really very important. That's what makes our job enjoyable for us, being able to develop those relationships and see people going through their treatment. What we've had in the past is quite a lot of single-handed consultant services, which traditionally has been appropriate because it has allowed us to put a lot of oncologists in the local DGHs. But as the treatment options have grown substantially, and therefore those clinical practices have grown substantially, it has become very difficult to be able to sustain that if you've got a single-handed consultant going to a clinic in, for instance, Barnsley, because if that consultant is off sick or is not there because of leave, then the service is being run by very junior members of staff, which is not a good experience. So we have been trying to consolidate into teams, and the teams need to be led by what we call a senior decision maker, which is usually a consultant oncologist. But actually we're pairing senior decision makers up or operating in teams of 3 or 4 of them. And we're also trying to develop senior decision makers in other disciplines such as pharmacy and nursing, so that they can oversee the more junior members of the team, and we have a safe service led by a senior decision maker regardless of other people's absences. So that's what we're aiming for. And that's why we've had to consolidate the number of sites that we do various things on. And the most dramatic, as you may well recall, was having to pull back from 5 different physical sites for breast cancer into 2 only when we had a bit of a collapse in our breast cancer oncologists. We are, alongside that, thinking very hard about the virtual offer. And I've talked before about the fact that telephone clinics are fine for some very transactional conversations, such as how are you post-radiotherapy? Brilliant, you're great. Can you get some blood tests so I can do a CT? We have struggled, I think, with the VTC consultations, but we've now got a project team together in Barnsley initially, trying to look at doing that in a much more structured way, so that the patient comes to their local hospital, has their local CNS with them, helping operate the equipment, because as you see, I couldn't even switch that on because I don't know how to do it, and sitting with them if the oncologist is talking to them about difficult stuff. Logistically, we have to put quite a bit of support in that, round that, to make that work. So we're starting that any moment now in Barnsley. Barnsley were very keen to explore that with us and looking to roll that out. We hadn't considered doing that in community hubs, but actually that's a great idea, and our charity has some really good relationships with a lot of those community places, and I think that is something that if we can get it working in the local DGHs, we would really think about exploring further. So thank you very much for that thought. The other thing we do have, and we're really lucky, is we have access to quite a lot of charitable transport. So in terms of trying to mitigate the effects of the fact that people will have to potentially travel at key points to see their senior decision maker or their team, the charity puts, our Western Park Cancer Charity puts on transport from all of the areas, working with Firefly and with Nana Kind. So we do have access to charitable transport. We have done a lot of work in terms of where chemo was delivered. So 3 or 4 years ago, if you lived in Barnsley, you would probably see your oncologist in Barnsley, but you would have a very high likelihood of having to travel to Sheffield to actually receive your intravenous chemotherapy treatment. So we've done a lot of work in pushing the delivery of chemo out to the local area. So in Barnsley, for instance, we also have chemo delivery at Burley Medical Centre. And we now know that for some groups of patients, although they travel to see their oncologist, they actually travel less because they get all of their treatment locally. So that's been an important piece of work that we're continuing to develop in terms of pushing more and more out to local delivery. We've done a lot of work, particularly with the breast cancer ladies, who found the transition from 5 centres to 2 centres really difficult. A lot of work in terms of what does a really good support pathway around them look like. You know, how can we make sure that they're getting the information they need when they need, that they can get the support that they need. We do try and look at car parking. We know that trying to park at Western Park is a disaster, and that's for the staff as well as the patients. Breathing Spaces, which is one of the places that the breast cancer team now work, has lovely parking, not so good for public transport, but lovely parking. So we do try and look at that. As I've said, we're looking at alternatives to non-face-to-face appointment. We are doing a lot of work on recruitment, and that's not just recruitment, but it's also retaining the people that we do have, as we have had groups of staff in the past that have gone to the Christie when their Proton Centre opened, and to other private hospitals down a bit further south. So we are doing a lot of work around trying to make ourselves an attractive place to work, and we have attracted 4 new consultants in the last round, which is amazing under the current circumstances, quite frankly. And at the same time as we were doing that, Manchester failed to recruit, so woohoo, well done Sheffield. We are trying to make sure that our teams work as much as possible at the top of their licence, so that I'm doing what really needs me and I'm not doing basic admin, which is why I'm so pleased our electronic health record hasn't landed yet. But conscious of the fact that if you're always working at the top of your licence, that's quite a stressful place to be. So just trying to get that mix right. We are a large and complex service, and I think Mark will agree with me that the operational processes behind us haven't always worked seamlessly. So we do have a service improvement team working with a lot of our operational teams to try and improve that. So, you know, there are times when communication with patients' last-minute appointments hasn't been great, but that's something that we are constantly working on. So as I say, we've recruited some oncologists. They're landing any moment now. Not all of them have worked previously in this country, so that, you know, that will take some time to have an effect. We are looking at the virtual working. We are continuing into thinking of the long-term model. So what we have described as a 3-phase process. We're stabilising services at the moment, and then we will go into improving, and then hopefully at some point be able to do something properly transformational. Service level agreements. I know it shouldn't matter, but the money that moves around the patch does sometimes get in the way of doing the right thing. And the service level agreements between Sheffield and some other places we work are no longer fit for purpose. So we are trying to sort those out. We've been trying to sort those out since I was appointed 20-something years ago. I'm hoping we may achieve that before I retire. So here's the key thing that we've been working on since we last came to see you. I'm a lung cancer oncologist. Lung cancer is one of the few things that we have been able to do in all 5 localities until recently. And last year, one of our lung oncologists had an extended period of time off sick, and it became apparent that we couldn't safely cover her service, and therefore the Barnsley patients had to travel to Weston Park to receive their care. So we have split the lung cancer team into 3 teams. Doncaster and Bassetlaw are covered by 2 consultants who go out there. Sheffield and Chesterfield are a team, and that left Barnsley and Rotherham, who were both in the hands of single consultant practices, which, as I said earlier, makes them very vulnerable to single point of failure, and the Barnsley point failed. So the Barnsley patients are currently being seen in Sheffield. We therefore wish to combine the Rotherham and Barnsley practices so that we have 2 consultants, 2 senior decision makers looking after that group of patients, and therefore always one of them there to supervise the team. We developed some criteria in terms of how we were going to decide which of those 2 places would be the better place to put the clinic. And as we were discussing those criteria, we realised that because access and transport is such a key thing in the feedback, we needed to consider somewhere that was in between, and the most in between place was Mexborough Montague. So we developed the criteria. We sent each of the organisations a form to fill in terms of how well they could meet those criteria, and then we drew together a panel, making sure that we had even representation from the localities to assess those bids, and the clear favourite for the whole panel was Rotherham, particularly on patient experience and safety. What I would say, reflecting on that process, was that the criteria we drew up felt like they were the right and appropriate ones. However, it did feel like quite a hard thing to do. I think a real sense of the responsibility of taking a service out of somewhere really hit us. But anyhow, the final decision is Rotherham. The next steps are the communication of that decision to the teams involved and the patients. We do recognise that in the longer term that's probably not the right direction of travel. So we know from the work that we've done with Total Lung Health Checks, the lung cancer screening van, that the highest areas of incidence map to the highest areas of deprivation, and the places that we have gone first are Doncaster, then Bassetlaw, then Rotherham and Barnsley. So in an ideal world, we would be looking, if anything, to push more out from Sheffield into those areas, but that is going to be part of the next phase of work, of the improvement and the transformation, trying to have a much better appreciation of where we need to put services across the patch, and Sheffield is not necessarily going to be the right answer for all of those services. So we recognise that this is where we are. I think we all strongly believe that's the right decision for this moment in time. But as I say, there's quite a lot of work to do about where we go next. And I think at this point in the proceedings, I more or less stopped talking. So we are still doing all those other things that we've talked about, the virtual clinic, the transport, and the pushing treatment out to home, closer to home. And I'm sure, having watched the last discussion, that there will be lots of questions for me, so I'll stop talking now before we run out of time.
Thank you very much. There will be questions, don't worry. I'm sure we can fill our time. Members, I just wanted to clarify that I think our meeting today was advertised from 1 p.m. to 3 p.m. We do normally run 2.5 hours as our standard time, so you may have been misdirected on that. So can I just check what time limit members have today? All right, thanks. I just wanted to check that because I'm aware that the timing wasn't quite right. Okay, so Councillor Stowe has indicated, and then Councillor Smith.
Mick Stowe, Barnsley. Thank you very much for answering a lot of my questions in your presentation. But it has raised, and you've given me some hope, because one of my questions were about equity in terms of Barnsley losing services. And we have, as you're aware, we've got Health on the High Street proposals in Barnsley. We are looking to develop diagnostic centre in town centre, which is going to release parking issues. It's going to release space in terms of being able to develop the hospital centre itself by moving diagnostic centre on top of what we've already done, which gets fantastic approval. Certainly from people in Barnsley anyway, and from shops and cafes and restaurants in the centre. So it's good, but Barnsley does get the feeling that services are being taken away. And what we need, in effect, is assurances that Barnsley is going to be part of. Now, I know Mexborough well, and I know facilities are a good facility. However, again, travel opportunities, certainly from Barnsley. And again, we were over doing a scrutiny with South Yorkshire Mayor only last week before, and we were talking about integrated transport opportunities. And we did highlight how difficult it is from Barnsley to Doncaster, because there's no railway services directly to that. So we do feel, but have you got any data that will confirm that Barnsley's getting equity in terms of their clinical needs since we moved the services centrally?
So, I think Barnsley and Rotherham are in a similar position in that we only had the one visiting oncologist at each. So Barnsley and Rotherham only had a lung oncologist going out. So we were conscious, as I say, when we went through the process of deciding that we were going to leave one hospital without very much oncology provision. I've heard amazing things about the glassworks, and I will get there one day. And when we moved the lung cancer service from Barnsley to Weston Park, we did watch very carefully the DNA rates and the rates of refusal in terms of the chest physicians referring the patients in, and we didn't see any drop-off. So I'm based in Sheffield, but I remember as a trainee, particularly going out to Doncaster and Bassetlaw, that people wouldn't come from the next village, never mind come to Sheffield. But actually we didn't see that happen. And as I say, we have moved the service from Barnsley Hospital anyway, so we're not actually pulling anything out that is there now. What we're not able to do is safely put it back at the moment. But as I say, we are really clear that this process comes in different phases, and what's happening at the moment is absolutely not the final state. It is what allows us to do the next piece of work, because at the moment at Weston Park it's all a bit frantic. We're always reacting to the latest disaster. I shouldn't say that. We're always reacting to the latest crisis in terms of what's happening with our staffing. What we're trying to do is get our nose out in front, which buys the head time for the teams to do the work. So we're very well supported at the Alliance by a project team. The project team, however, gets somewhat frustrated because the clinicians that they need to interact with to help build the future model and discuss how we're going to work in the future are too busy doing an impersonation of a headless chicken back at base to engage. So what we're trying to do is get to the stage where we can get the clinical stability that allows the clinicians to be more integral to the piece of work that we're trying to do. And as I say, this is not about pulling everything in Sheffield. You can't park in Weston Park. Our physical site is not big enough. We don't necessarily think another site in Sheffield is the right answer, whatever you may have read in the newspaper. So, in fact, we're not even really talking about buildings at the moment. We're talking about what is the right clinical model, because until you've got the right clinical model, you don't actually know what buildings you need. And in the longer term, what we would like to see is more heavily spec'd multidisciplinary teams. So I've described the marvellous team that I work with in Sheffield, and that happened because I was clinical director of Weston Park at the time, and I was trying to persuade my colleagues that they needed to work with all these highly spec'd HCPs, and they went, oh no, we're not doing that. So the only way to, of course, win hearts and minds is to do it yourself and show them that it works. So now I have this lovely team around me, but my colleagues in the localities don't. So what we think the future direction of travel may be is having a lot of these very specialised people more widely spread across the patch, which then allows the reduced numbers of consultants to be supervising orchestras in different hospitals rather than supervising an orchestra that's still mainly in Sheffield.
I think what we need to flag up in Barnsley is the indices of deprivation in pockets, because life expectancy in Penistone is 10 years longer than it is in Durham. And I think that's important because our industrial past has led to more chest, more lung issues in terms of not only cancer but other minor related diseases. And I think we need to be looking. Then Mexborough might be the spot for Durham because they're only next door to each other, but I think we need to be mindful of Barnsley's issues, in particular around deprivation.
Yeah, and we see that in a lot of the localities. Doncaster is very similar. There's very specific spots of deprivation. And like I say, we now have that level of detail because of the total lung health checks information, which has really, really made us think differently about how we put stuff in.
I just wanted to make a little comment, Trish, because you've referred twice to the violinist having to find themselves conducting an orchestra, and I just wanted to put a bit of reassurance in, as speaking in my day job as a musician, that a lot of medics are also very fine musicians. One point I've noticed through my life, and also there is a long history of violinists turning conductor very successfully and very skillfully. So I've no doubt that the people finding themselves in those positions are doing a very fine job and managing the situation, whether they wanted it or not. So just to put a bit of credibility around that, is, you know, skills are very transferable, and I'm sure they're doing a fine job. Councillor Smith. Oh, sorry, Councillor Turner first, and then Councillor.
Just an observation from a recruitment point of view, and painting the picture. I find it really difficult to understand how you can't get staff into these areas where probably have some of the cheapest homes in the UK. And so, are we telling people the right story?
So,
sorry?
No, I'm just saying, do people want to come and live in Grantham?
I play football there, mate.
sorry, I'm sniggering because I fell out with a very pompous oncologist in London who just bought one of the new electronic BMWs when they first came out for £150,000, at which point I pointed out you could buy 2 houses in Crooks for that. Anyhow.
Exactly my point, yeah.
So at one stage, STH adverts always included a big picture of the Peak District with a mountain biker. And there was a lot of discussion about the fact that we didn't necessarily want to recruit A&E consultant mountain bikers to all of our posts. So we have tried to use different ways of attracting people. I think that if we can get people into Sheffield, they rarely leave. You know, it's a lovely part of the world to live. I trained in lots of different hospitals, which at the time was great, although living out the back of a car wasn't. And I loved Sheffield when I landed here in terms of, you know, the countryside, the people and all the rest of it. The difficulty is that when you're, as a registrar, looking at different consultant jobs, you're often looking more at the hospital than the city. And when I was clinical director and stalking trainees as they moved through their training in different parts of the country, we would get people up and they would say, this is a lovely place, you've got a lovely team. They would apply for a job and they would withdraw at the last minute because they had been to somewhere bigger and sexier with fancier bits of kit.
Fair play, yeah. Just a couple of questions, yeah. Literally going back to previous agenda item questions, so regarding Bassetlaw residents, again in the report, and the lack of detail in there for Bassetlaw residents, because I understand it's under the Doncaster banner. Is there some way we can
pull that out?
Pull that report out for Bassetlaw residents?
We can. I think that so there's reference in the report to location being Doncaster, and sometimes that's correct that it is in Doncaster, the locations that we're talking about, but where it talks about patients and it talks about Doncaster patients, that is Doncaster and Bassetlaw patients. We can see if we can pull out some of that information. And just back to your previous question, I think Trish mentioned it, but that recent successful consultant recruitment that we've gone through, I think is testament to some of the things that we're doing and trying, and that really targeted work, but also we sort of talk about more glossy approaches to recruitment materials, which we are investing time, energy and effort into, and I think it is paying off, but it's a perpetual effort to try to encourage particularly consultants to come to and stay working in Sheffield.
Thank you. And just one more question. Are we sure all Bassetlaw residents travel to Doncaster, not Sheffield, for oncology treatment?
I think the vast majority of them do go to Doncaster, yes. There will be the very specialist stuff that we can only do in Sheffield. So in Doncaster we have most of the common cancers treated locally, so lung, colorectal, urology. The breast ladies are obviously travelling into breathing spaces, but will have their treatments, most of their treatments in Doncaster. We have one of the issues with the service level agreements and arguing about the money is the increasing delivery of chemotherapy workload, and where some of that is given when the units are staffed to do a certain amount of work and are reluctant to take on additional staff to do additional work unless the money is agreed. Like I say, it honestly really shouldn't matter, but it gets in the way of all sorts of stuff. But we are trying as hard as possible to push more and more out to the localities. But there are the rarer cancers and the more complex stuff that involves particularly radiotherapy, but also some of the longer chemotherapy regimens. So some of the chemotherapy we use takes 8 or 9 hours to deliver. Back at Weston Park, where we have, I don't know how many chairs anymore, I'm going to guess at 50, to have 4 or 5 of those occupied all day isn't that bad. But if you're in Rotherham, where we've only got 6 or 8 chairs, to have 2 of those occupied all day actually takes a lot of capacity out. So that there is a bit of stuff that has to move around because there's no other way of doing it. And there's a bit of argy-bargy about the money, but most people will get most of their treatment locally.
So is there a case for pushing treatment back out to Basildon?
So we do chemotherapy delivery wherever we can find a staffed unit. What we have seen recently is that because of some issues with our chemo nurses who deliver the chemo, we've had to not run Burley at short notice on 1 or 2 occasions when we can't safely staff it. So most oncology centres have an issue with managing the increased volume of work. Our particular issue is the workforce in terms of the oncologists, but you may recall that Nottingham, 18 months, 2 years ago, stopped delivering most of their chemo for 6 weeks because they had no chemo nurses to run their delivery unit. So for places around us, it's chemo delivery trained nurses, or it's pharmacists, or it's physical space in pharmacy to be able to make up the volume of chemo. So there are lots of, nationally, there's a huge bit of work going on looking at all of the different issues that the different units are having in terms of managing this huge escalation in workload.
So it's like going back to the first part I mentioned.
Yes. Yeah. It's all these complex interdependencies, and obviously what we do when we come to you is give you a snapshot, but it's very, very complex.
Thank you. Councillor Smith.
Thank you. I'm really reassured that you've recruited 4 consultants. We have to keep them now.
Exactly.
So retain them in Sheffield and possibly breed our own, because that always works very well. Whilst I get that we skill up the staff that we have, and personally, and I'm speaking personally, comfortable with advanced nurse practitioners, I'm not as comfortable with associates. I'm pleased your experience is very positive, but I'm kind of getting from how it was described that they're very much working under supervision.
Absolutely, that's the key.
Yes, and that, you know, that there are reassurances in place that that will be the case.
Yeah.
For the future. And the other thing that I would wonder is how they are introduced to the patients, I suppose. So what's said, and so that the patient understands that this isn't a doctor that they're, you know, that they're speaking to.
Yeah. So we have 3 physicians associates at Weston Park, all based at Weston Park. They don't travel out. I work with Danny in the lung cancer clinic, so she looks after the inpatients, but she does a clinic with me on Thursday. As you know, physicians associates can't prescribe and they can't order radiology, which in a lung cancer chemo clinic limits them. However, what Danny does for me is see the new patients. And she introduces herself appropriately. She does the initial chat with the specialist nurse with her, and then she comes and presents that patient to me, and I go back in, review the patient, agree the final plan. I then swan out of the clinic room, book all of that, while she and the CNS are taking the patient and their family through the detail of what that means, and then Danny does all the dictation and the paperwork. So it essentially means that instead of it taking me 45 minutes to see one new patient, in 45 minutes I can see 3 new patients. So she's always very careful to introduce herself appropriately. If she sees, occasionally if we haven't got enough new patients for her to see, she will see the occasional follow-up, but again, they will always be seen by a doctor. So it doesn't stop us having to see those patients, but it does make us more efficient when we see them, so that we can, as I say, see more people in the same time. We don't have any plans currently to increase our numbers of physicians associates because their use is quite niche at the moment. I think Danny is actually probably better at assessing some of the patients than our registrars are, because the rest of the week she largely spends on our wards and admissions unit. So she sees what happens when we make these people ill, and she's very sensible in terms of assessing people's fitness for what we're going to put them through.
Could I just briefly come in on your point about growing our own as well? So we talk about the 4 consultants, and that's quite an emblematic point as well. But over the last 3 months, we have also additionally appointed 4 specialty doctors. So these are senior doctors, 2 in breast, 1 in head and neck, and 1 in urology. And then I think it's right that all of our training places are also filled as well. So these are people who've expressed an interest in working in Weston Park, and then that sort of growing, that future pipeline is also in a much stronger place than it has been previously. So although there's a long way for us still to go, I think we do feel much more confident about that medical workforce over the coming years.
May I just clarify, in the report it refers to advanced clinical practitioners as a role. Are we talking about physician associates? Is it the same thing?
So advanced clinical practitioners, we're normally talking about nurses and pharmacists and occasionally therapy radiographers. I don't think we've referenced physicians associates in the paper. I think it was just me describing how I worked in clinic that slipped in.
Councillor Keenan, you had questions.
Thank you, Chair. We heard from the member of the public that came to ask the question about terms of reference, the importance of the patient's voice, the importance of patients being heard, and there will be people watching today that will be using the services and really do want their voice heard. Yeah. Can you reassure us, and can you maybe let us know how the ongoing opportunities for capturing that patient voice and what you are able to do in that respect? And can you reassure us that you're reaching out to some of the harder reached communities that we represent and we see, please?
Yes. So firstly, and referenced in the appendix, we did do a very big piece of work at the beginning, which we presented in some detail on one of our early visits to this committee. But we do have within the Alliance what we call PAB-CAB, which doesn't really slip off the tongue. That's Patients Affected by Cancer, something or other board, which we use extensively to take them stuff in terms of things we're thinking about doing, but also to listen to what it is they're talking about and raising. Within the Alliance, there are also some other really key pieces of work that have been going on, not within this programme, but nevertheless the learning feeds into this. So in terms of screening, we've done a really big piece of work in terms of who doesn't come for screening, and how some of our disadvantaged groups and disabled groups can be encouraged, and what support they need to come. The Total Lung Health Checks, there's been a brilliant piece of work when Total Lung Health Checks was in Doncaster, I think it was, at the beginning, in terms of trying to make sure that people with disabilities or learning issues, or any other reason why they may find it more difficult to attend for a scan, could be supported to come. So we do a lot of work within our programmes to try and think hard about reaching out to communities and populations that haven't traditionally engaged. There was another programme, and I can't remember which one it was, where we were doing quite a lot around the Romani populations in terms of trying to get them engaged. And there's something else I was going to say, it's gone clean out of my head there, but Mark looks poised. It might come back to me in a second.
Whether it's what was in Trish's head, I don't know. But I think I was also going to say that there's a project underway at the moment with MENCAP and Barnsley Healthcare Foundation, one of our primary care networks, there to look at screening. I think in the 11 weeks so far, we've seen a 29% increase in uptake from those groups for a bowel screening programme. And yeah, there is further information in the report about the listening exercise that we undertook last year. So 950 people engaged with that, but of the 950, just over 100 declared they had a disability, and we've ensured that we've got ongoing engagement with people from those seldom heard groups, and that might be due to deprivation or other characteristics. So that's an ongoing part of the work.
And I've just remembered what I was going to say was the big purple bus. So the charity Western Park Cancer Centre has 2 repurposed Macmillan buses, which are now big purple buses, which go out into various parts of the population. For instance, Darnall, working with the community centres and working certainly initially with different religious groups. So, for instance, trying to understand what it is that stops Muslim ladies coming for breast cancer screening, and the answer is because they don't like taking their clothes off in front of strangers, and that sort of thing. So we work very closely with the charity. They have one bus that has a fixed route so that those populations know that they're coming regularly, and another bus that they use on a more ad hoc basis to try and get into new places. So there's a lot of learning from that, not just around religious groups, but around other populations that find it difficult to come. So we're trying to take stuff to people where we can, rather than expect people to come to services.
That's really good to hear. There's a lot of learning for councils as well about going to where people are instead of expecting them to come to you. So I think we're all very mindful of that. I've seen the big purple bus in our city centre when they ran a day stationed right in the city centre here in Sheffield, just outside here, on a melanoma awareness day, which was really successful. Loads of people dropping in and taking away the little freebies of sunscreen and so on. It did look a really worthwhile thing. So.
Yeah, one of the last things I did before I stopped being a trustee was persuade the other trustees that not quite 2 for the price of 1, but 2 buses was much more important than 1 bus, because we could do so much more with it. And they agreed. So we have 2 big purple buses.
That's brilliant. I've just got a couple of questions, if that's okay. So a transformation programme is a term we're very familiar with. Over the last decade or so in health services. So looking at the paper, it does look like now a really comprehensive piece of work, and that the transformation will be around the service in the round, rather than just looking at breast and NSO or any other part on its own, and not just outpatients, but broadening the whole scope seems really sensible to me. But from a layperson's point of view, I think the words transformation and sustainability have come to mean something negative, and essentially cuts. And that's, it's part of the course when we see transformation or sustainability, and of course the previous incarnation of ICSs before they took statutory powers was transformation and sustainability and transformation partnerships, wasn't it? STPs all those years ago, which just became a byword for cuts, essentially. So what kind of assurance can you put out to people who are worried that this transformation work is not in total a cut, to anything, but actually it will result in the same or better.
So, we absolutely do not see this as cutting anything whatsoever. I think it would be fair to say that for most of the time that I've been a consultant oncologist, cancer has been a clear priority nationally. Don't see that changing at all. We know that we've got a pipeline of yet more drugs coming through, and we know that NICE approves most of them. Having worked in a period where NICE said no to everything, NICE now says yes to just about everything that comes past it, even when the trials aren't particularly mature. So everywhere is gearing up to do more and more and more. It's all about how we sustain that huge explosion in what we do. And it's about how we almost make it everybody's job to look after cancer. We had a really good strategy session where a very sensible public health person came along and looked at it completely differently to us and said, well, this is like diabetes was 10 years ago. You know, there's too much work for the diabetic teams to do on their own, and therefore you've got to make it everybody's job. So it's that sort of thinking. We are going to get to the stage where, quite frankly, we put some of these drugs in the tap water, I think. We are going to get to, I mean, it's gone from 1 in 3 people to 1 in 2 people in their lifetime will get cancer. I can't see cancer not being a priority for health services. I think we've got to get better at managing people with multiple cancers and multiple other conditions. So there's a whole load of additional stuff. If you let me talk for the rest of the day, I'd talk about geriatric oncology and all sorts of other stuff, and you know, how we integrate with a lot of the other teams that we work with in terms of the huge array of new toxicities that we create with some of these new drugs that we use. So absolutely not about cuts. It is about how we safely maintain this workload, and how we do try and make it everybody's business, because the oncologists on their own can't do it.
Thank you. And finally, I just wanted to ask about staff wellbeing and the upskilling programmes that have happened as part of this stabilising phase of the programme. And so you've commented that staff working at the top of their licence can have an unintended consequence of that person working in a very stressful situation the whole time. I just wondered if there have been any losses in the workforce because of that. So have people come to the top of their licence and found it actually too overwhelming to be working at that level the whole time and moved on? Or cut their hours to cope with that? I mean, that's a pandemic across many workforces, is being in that stress every day, and so you cut your hours to deal with it. Or have any staff left to actually, once they've realised they've got these skills, have they taken those skills elsewhere, perhaps to go up a grade in a different service in a different part of the country, because you know, that might look more attractive?
So yeah, absolutely. So we have definitely lost people that we have successfully upskilled and been poached by other places. And particularly at the beginning, when we had upskilled a small number of people, that was really quite challenging, because we would lose capacity when they were stolen. I think now that we have upskilled many more people, we can, though it's not ideal, cope when they're poached, but also because they're not a minority species, they support each other. So we now have a very big team of upskilled HCP, ACP nurses who support each other in their training and in their working. In terms of staff wellbeing, I think that is one of the things that we all really worry about. We definitely lost a couple of consultants 18 months, 2 years ago now. One went to The Christian one went to Clatterbridge because they were offered what looked like a nicer package. One of them was never going to come back. One of them might have, but has decided not to. Interestingly, we have, we think, persuaded somebody who went to Clatterbridge to come back. So the grass is not always greener on the other side of the fence. It's just a slightly different set of issues. We are aware that a lot of our colleagues are very stressed within the consultant body, and we do try and support them as best we can. The difficulty is that in supporting an individual, you're often therefore offering less support to somebody else. We haven't got the additional support for everybody. So it is a bit of a kind of try and keep as many people okay as we possibly can. We have tried to put back in what we used to do when we were a smaller organisation, is all come together fairly regularly, but that's now much more difficult because of the pressures that we work under. But we have consciously tried to put in more occasions for the teams to come together, both within the hospital but also the charity. There's a big breakfast every now and again. And then the top team combines that with a bit of an update in terms of where we're going. I think what we all know is however much you communicate what you're up to, it's never quite enough. So all those opportunities to get people together to talk again about what we're doing and therefore feel like we're a team supporting each other, you know, we try and make those opportunities and we try and look out for each other. But there is no doubt that it's still quite a stressful work environment.
Thank you. Is there anything else from members? Any other questions? I think we're looking at the whole picture, we're maybe, you know, there's maybe a little concern that whilst you're in the stabilisation phase here, whilst that work's been ongoing, there's the lung part of this picture has obviously gotten worse. We can see that in the report. They've had to close one of the locations. So is everything else sound, or is anything else at risk? So there's urology, there's specialist cancers. Is anything else at risk at this stage, or is this stabilisation working?
So I think in the bigger teams, with this change with lung, we should have consolidated sufficiently. What I would say is that some of our other smaller teams, and I'm thinking particularly of the CNS, the Central Nervous System team, are more vulnerable because they've only got 2 consultants doing the whole of the geographical patch, for instance, and one of those consultants is retiring earlier than planned. So there are still issues in the rarer, smaller teams that would mean that we would be vulnerable if anything else happened. So whilst I'm not aware of anything other than the CNS team, and I don't know whether Mark's going to come in here, what I couldn't do is say that we wouldn't get a nasty surprise in one of the smaller teams if something untoward happens in terms of illness or what have you.
I think probably the urology pathway, we're working closely with the team on to make sure that urology pathway is secure. I think the breast position feels a much better place than it was certainly 2 years ago, and probably as recently as 6 months ago. That does feel better. I think urology is not in the same place that breast was, but we need to support the team to make sure that urology capacity is sized for the demand that's coming through.
Okay, if there's no further questions, well, thank you for both coming and for being willing to answer our questions today. I know we do demand, we demand your time every now and then, so we're grateful that you've come and spent so much time with us. Our recommendations on this item are firstly to note the approach to the non-surgical oncology transformation programme, which I think has been explained fully to us today, and to note the progress being made as part of the stabilisation phase, including the temporary development of a 4th lung clinic site for Rotherham and Barnsley patients, which is a new development since we last heard from you. Are we agreed to note those two things? And is there anything further that members would like to add in terms of how we might hear back about this in the future?
Yeah, I'd like to know when progress or the map to progress for Barnsley and Rotherham comes into place, and let us know, please.
Yep.
Would that be something you might take specifically to
Barnsley
Place
Yep.
and Rotherham Place?
Yep.
Or, and maybe copy of other members of this committee in it. So if there's a significant update to that, if that could be circulated to the relevant members in a timely way, that would be useful. And otherwise, do we want to receive a further report on the transformation programme 6 months? Yeah. Yeah. Does that sit okay with you?
Yeah.
Yeah. So roughly April next year.
Thank you.
And just wishing you all the best as you carry on with the work, which must be very draining. So thank you for what you're doing.
Thank you.
Okay, we've just got our item on the work programme, which Deborah will set out for us, and then we are at the end of our agenda. Deborah's computer has logged itself off.
Thanks, Chair. I think it's fairly self-explanatory. It's a forward plan of meetings. We don't actually have any set dates yet, so myself and Joanne will be looking to firm up those dates for the next 12 months as soon as we can, really, because obviously it's important for us to be able to give colleagues in the NHS kind of notification of when they want, when we're wanting them to attend, and also from the point of view of members' diaries, it's really important to be able to get them in as soon as we can. We did have a date for December, but I think we're going to have to revisit it because we've subsequently found that there is an issue with everybody being able to attend. So I will look to get the next 4 meetings dates set as soon as possible. We have still got the Yorkshire Ambulance Service strategy item. I have been informed by them that their strategy is in place now, so it's looking at implementation. So the report would be more around implementation of the strategy and how they might review that moving forward. So that hopefully is going to the December meeting. You've also got an update report on the Mexborough, I can't remember the name of the service that was based there in Mexborough, but Orthopaedics, that's it, thank you. So the Mexborough Orthopaedics Centre will be giving a 12-month update in December as well. But I think it's fair to say, as always, if there are any issues that are coming up in your localities that you feel need to be or could usefully be looked at a regional level, then feed those through to the work programme.
So in terms of the 2 updates that we've just agreed to request in 6 months, we don't have a meeting scheduled for 6 months, which would be April. We've provisionally got March and June earmarked. I'm aware that some authorities will have local elections and therefore a pre-election period which will suppress our activity. We don't in Sheffield in 2025, but you're all nodding, so I assume you've all got local elections, which would mean that the whole of April is out, and the first week at least of May. So do we want to look at as soon as possible in May to pick up things that we've asked for 6 month updates? Should we attempt for a meeting in mid-May?
Would it be too soon for March?
We could do March just before PERP kicks in. So we could see if we could fit, so either the end of March before PERP kicks in those places with elections, or as soon as is reasonable in May.
Because I'm minded Sheffield ain't got elections, Barnsley ain't got elections. And so we'd be flexible. And Rotherham ain't got elections. So as long as we can work round others who have got elections, that would be good.
Yeah, and mid-May might be quite busy for the team in terms of just following the elections, the induction.
So we'll see if we can shoehorn it in March, just before we go into the restricted period. We can hear reports during the pre-election period, but I know it's obviously difficult for members, as you know, when campaigning has started. That's not where your attention is, because you need to be, you know, interfacing with constituents. So it's not ideal, but we can, in extremis, schedule a meeting. We have held a scrutiny here in Sheffield during PERP, and we just had to be fairly stringent about party politics, essentially. But I mean, we haven't entered into that today, so I think we're all working to the same end on this anyway. So Deborah will try to fix those meetings as quickly as possible then. I know it's difficult, but we'll do our best. Okay, so thank you everyone for attending, and thank you for the support from our officers today and from our technical team, and see you next time.